Audio recording for this meeting has begun.
He's a real rock star in this world. I don't know how often Dr. Halfon gets introduced as a rock star, but there you go. But Dr. Neil Halfon is the founding director of the UCLA Center for Healthier Children, Families, and Communities, and also directs the Child and Family Health Leadership and Training Program at UCLA. Many things he's done at UCLA, but most importantly, in my mind, nationally and internationally, he is known for talking about the life course. Again, what happening early, having impact later, and that it's absolutely critical that we do what we can to improve the lives of children and young families, because without it, we are really shooting ourselves in the foot hugely. So Dr. Halfon is going to talk about life course. Again, he's advised many national committees and been part of them. And it's just you're hearing from one of the gurus here when you hear from Dr. Halfon. So please join me in welcoming him.
Good morning, and it's a great pleasure to be with you today, and I was really honored to be invited to participate in this meeting for several reasons. One being that one of my mentors was a guy named Phil Lee. Phil was the Assistant Secretary for Health for President Johnson, rolled out Medicare and Medicaid, then came back for President Clinton and did the same. Worked on a whole variety of things as the Assistant Secretary for Health. And he said to me at one point, he said the most fulfilling thing that he ever did in his national service and running the HHS was working with the IHS. And he says, if you ever have a chance to work with the Indian nations, you should run to it, because he says you'll never find a group of people who are more committed doing things in the right way and making the right kinds of changes. So I'm finally glad that I'm here and here with you. I'm going to be talking about life course, and just to give you a sense of sort of how I got into this business. And it goes back more than 40 years. When I was a first-year medical student, I had to do a psychiatry rotation my first year at UC Davis, and I chose to do the psychiatry rotation for 6 weeks at the Vacaville State Penitentiary. And the reason why I did that, I was interested in social justice issues and found myself in the main line of this prison learning about what goes on in the lives of people that are incarcerated. And what I learned was, and I didn't spend 6 weeks there, I spent a whole year sitting in groups therapy sessions with a group of men who had been incarcerated. And they had done some pretty horrible things. But what I learned was every single one of them had a number of traumas in their lives. There was no accident for them being in prison. It wasn't a bad seed thing. It was about what their lives had been like. And the same Phil Lee, when I finished my residency in pediatrics, got me involved with doing a study on children in foster care that led to me starting something called the Center for the Vulnerable Child at Children's Hospital in Oakland, and I took care of, probably 1,000 kids in foster care. And the dominant model at that time was still the biomedical model, and the biomedical model said that anything goes wrong with you, it's either a gene, a germ, a chemical, some kind of molecule that you have to figure out to do things. And as I took care of all these kids in foster care, what I started to realize as we looked at their growth trajectories and their head circumferences and what they did, you saw how much their trajectories in life were directly related to their social circumstance. It wasn't genes, germs, or anything else. It was about their environment. It was the ecosystem that they were living in that determined sort of what was going on. And so that really changed the way that I saw things and what I did. So just to give you a sense of where I come from, I'm from a center called the Center for the Healthier Children, Families, and Communities. And we set up the center because most of what we do in medicine and in healthcare and everything else is all siloed in vertical silos. And we're sort of horizontalists in this vertical world. And we do systems innovation, and we do training and research and policy. We have a series of projects we're doing, one called All Children Thrive, which is a global project trying to change the ecosystems in which children live. And I'm going to talk about it because that's where all our life course work is headed. We have something called All Children Thrive California. We were given $10 million from the state legislature to deal with ACEs and to try to do it at a community level and a systems level. We're doing something called Transforming Early Childhood Community Systems. We're working with 70 or 80 different communities around the country, from places like Washington, D.C. and New Orleans, to small places in Texas. And what we're doing there is providing measurement systems so children aren't invisible and their developmental trajectories can be measured, and communities can take charge of that, and they can create people-powered solutions that are customizable to what they do. We're developing something with the Robert Wood Johnson Foundation called the GDP2, which is a new measure of progress. And what we're trying to do is begin to not just use the GDP, which is about how we consume and how we're sort of using the Earth's resources, but how do we measure the gross domestic potential? How do we measure human potential in communities and as a nation, so that we sort of shift our focus to well-being, resilience, and sustainability? We have a project called Moving Healthcare Upstream. And then last, we run for the Maternal and Child Health Bureau something called the Life Course Research Network, and recently funded Life Course Intervention Research Network. And I just mention this because any of you that are really interested in doing life course interventions, we both have money, a whole group of scientists from around the country that are interested in working with communities and individuals that want to make a difference in this regard. Part of what we're about is trying to think differently about things, and I hope some of what I'm going to talk about are some new ideas and new frameworks, and really echo what Anne has just talked about. And the basic bottom line is you need to start early and really focus on those things that have the most impact. I'm going to talk about life course health development, and life course health development is an analytic framework or model that they use to make sense of the world. It's a sense-making sort of approach. And I know that diabetes is one of several health problems that is more prevalent in Native Americans. It's not the only one, but it's a good model system. When I was in medical school, they told us if you want to know everything about medicine, just study diabetes. And it's the one disease that'll teach you everything that you need to know about the human body. But I'm going to use life course as a way of thinking about a new way of thinking and connecting the dots between what happens early in life and what happens later. I'm going to explain how health and disease develops, and thinking about health as a developmental phenomena, and focus on multiple ways that risk and protective factors get under the skin and what that's all about. Part of what I'm going to do is I'm going to put it into a framework, and I'm showing these three horizons because we need to make some major changes in what we're doing. And the first horizon of change is the thing we always go to, and it's the easy one to go to. Those are incremental changes. Those are changes that are about quality improvement, a new screening tool, a new this, a new that, but it's within the way we can currently do things. The second horizon are innovations that are disruptive, and they're purposely disruptive because we're trying to take our practice to a higher level, to take it and do differently. And that's more risky and harder to do, but it's often what we need to do. And the third horizon is something off in the future. It's a transformative innovation. And I'm going to argue that for our kids in this country that are suffering in poverty and trauma and various other things, we can't do incremental things anymore. We need to be thinking about disruptive and transformative things. And those disruptive and transformative things have to be done not in lockstep or some program that can be implemented everywhere. It's about learning faster and customizing and doing it in your community. So I'm going to be talking about that. So life course health development is helpful in rethinking and redefining how we go from a 1.0 medical care system, 2.0 healthcare system, to how we actually get to a health system, something that's actively producing the health of the population, and how it's useful in considering culturally coherent developmental scaffolding that responds to and buffers the effects of historical trauma, that advances decolonizing methodologies that I know are really important to this community, that redefines clinical strategies into really developmental ecosystem. How do we change the ecosystem in which children are living? And how do we start thinking about how we do that? And to prioritize and position cultural revitalization that I know that is really important to you all, that this is really consistent with? And how do we start thinking about ways that we move to that third horizon? So just to set a more stage setting before I get into it, we're going through some big complex changes right now as a society, as a world that's going on. We have to make major adaptive changes. Climate change is just one of major things, tsunamis that are affecting the whole planet. Responding requires these transformative approaches. We need new paradigms so that we can make sense of the world in a different way and enhance new strategies. It really requires us understanding complex systems, complexity, wicked problems, and ways that we can change these complex systems. And this life course framework provides a way of doing that and thinking about it. So when I talk about the deep drivers of adversity, we talked about adverse childhood experiences. We know that marginalization and poverty and these things are bad for people, and those have been with us for a long time. But we're going through something right now that's rather profound. We're going through a change of age. And the change of age, we're going from an industrial era to a digital era. And the change of age, when we went from being an agrarian society to an industrial society, people got sicker, they got shorter, they developed all kinds of health problems when we went through that. And it took about 100 years to figure out how we did deal with child abuse and juvenile delinquency, and we still haven't gotten over it. But that was about people moving from rural areas into cities and living in a very different way. We're going through something very similar right now. We're going from an industrial age in which we lived and made money and organized ourselves into this whole new society. And right now in the United States, 80% of the population is dropping in their value and worth, and only 20% are going up. And inequality is just going up like that. So we're going through this massive change that's affecting all of us. So the ecosystem's changing. And we're going through major disruptions that are going on in our cultural forms and our value streams, production models, relationships to the environment and planet. And these things have been happening in the Indian nations for hundreds of years right now, but it's happening to everybody at this point. And that creates a certain opportunity because there's lots of room for innovation and change at this point and try bigger and bolder things. And the accelerators of this change have to do with globalization, technology change, climate change, and the speed of change is happening. It's faster. It's almost like the world is spinning faster and faster and heating up as it spins faster and faster, as we just sort of push the gas pedal to make more and more money, and all the money is going up just to sort of one group of people at this point. And we're getting all these mismatched diseases. So diabetes is a mismatched disease. Obesity is a mismatched disease. Mental health problems are mismatched. It's mismatches between who we are as human beings, how we were defined by evolution and the environments we've created for ourselves. And Tom Friedman from the New York Times has used this little graphic showing human adaptability, how our technology change has increased. And what you're seeing there on the top is we're actually have evolved to the point where our technology is far greater than who we are at this point. We have this big gap between who we are and what we're being asked to do. So part of this new framework is to respect the dignity of people, culture, and ecosystems and be sympathetic in a useful way, to focus on assets, to enhance capabilities, to escape the pull of historical trauma and the structural inequalities, identify and leverage root causes, build connections between the different levels, personal, interpersonal, cultural, community levels, and explain the mismatches. So I've done a really long introduction, so when's this guy going to get to the meat and potatoes? But I want to sort of set the stage for what we're going to do. So part of it is moving our conceptual models. Most people don't think about conceptual models, but medicine and what we do clinically has been largely defined by a biomedical model that said that basically it was a gene, a germ, a chemical, something in your metabolism that caused all these problems. And this is historically what medicine was built upon, and our hospitals and clinics and everything else is built around this model. And this is a simple mechanistic linear model that just connects the dots in very simple ways. And then what happened is, because of the Framingham study, which was an epidemiologic study that said that heart disease wasn't just about bad luck and bad genes, but was about what you ate and when you were exercising and whether you smoked and various things, and a whole variety of behavioral research, we come up with something called the biopsychosocial model. And what that suggested was not just biology, but your behaviors and your environment that affected things. In 1977, George Engel published this article on the biopsychosocial model, and it's a different model. It says there's multiple things acting at multiple levels, and we understand the social determinants of health influencing our biology and what's going on. But what's happened over the last 30, 40 years is we've had this just unbelievable amount of research that has shown us through lifespan development, through neurodevelopmental research, the brain research, the research on toxic stress, all this epigenetic research, that there's more to it than just the biopsychosocial, that timing is important, that things that happen in early life are important. And this is where this life course health development model is. So we've gone from kind of 1.0 to 2.0 to 3.0. It's a different way. And it's really a complex relational, developmental, dynamic model and way of thinking about things. So as we think about this, just to apply it, we need to recognize that we're seeing very rapid changes in the epidemiology of childhood. We've made remarkable progress, just like you've made remarkable progress on end-stage renal disease, treating diabetes. We can fix hearts, we can do all kinds of medical wonders and what made great technological progress. But what's happening is the number of kids with chronic health problems is skyrocketing. We now have 40% of kids that have chronic health problems. And it isn't hemophilia, cancer, and congenital heart disease that are going up. It's not the stuff that you're taught in medical school about medical diseases. All those things are pretty stable, or we've gotten better at doing it. What's going up is obesity, metabolic and diabetes. We're seeing growing prevalence of mental health disorders, with 22% of kids in adolescence having mental health disorders that are impaired. We've seen greater appreciation for these neurodevelopment disorders, autism and ADHD, and we have lots of kids that have multiple conditions. And what we're seeing is, this is just a trend line from the National Health Interview Survey of looking at children with disabilities. And what you're seeing from 1960 to 2008, it just continues to go on. This is my own research. And so we see the number of kids with chronic conditions that has just continued to go on, disabling chronic conditions. And this is like, you know, almost no one's paying attention to this, like it's just continuing to go up. And what's changed is, in 1960, the poster child for a chronic disease in 1960 was a little girl with crutches and braces on her leg that had polio. And a poster child now is a little boy with autism or some other kind of neurodevelopmental or mental health disorder. And we know that depression is going up and mental health disorders. We've just had two recent sets of studies that come out that show that the suicide rates in young women and girls have tripled in the last 15 years. The self-harm rates in young women has gone up threefold also. So 17% of young women from the age of 16 to 22 or 24 are harming themselves. This should be like a 5-alarm fire. The sprinkler system should be going on in society. We should all be soaking wet because of this. But we're not really responding at this point. And we know that in the Indian nations that we see really differential morbidity and mortality, with the death rate still very high, and the number of problems are higher, but you're also making much faster progress than others, because you sort of have figured out that you need to come at it in a more holistic, ecological, cultural way. So right now we have 4 to 6% of kids with severe disabilities, 14 to 18% of kids with special needs, 30 to 40% of kids with mental health and behavioral learning problems, 50 to 60%. I'm just kidding that they're good enough. No one's really good enough. When you look at your kids, you don't say you're good enough. Well, unless you have an adolescent, you say you're good when they come to you and you sort of say you're good enough. But we want our kids to be thriving. And so, but this is not a prescription for thriving. We're not moving in a thriving direction. So we have these ideal developmental trajectories, and our current practice leaves this extraordinary opportunity gap. So how do we sort of overcome this? So how do we think about life course? And these are ideas that have been around for a while. This is from an ad from Blue Shield of California from 20 years ago, connecting what happens early to what happens later. There's been thousands and thousands of life course studies over the last 20 years, connecting, putting the science out, and I'm just going to review a few of those now. We've just published a book called The Handbook of Life Course Health Development. It's online, it's open source, you can download the whole thing, and we did this as part of this MCH-funded Life Course Intervention Research. So the basic idea is it defines health as a developmental process. That's what Ann was just saying, is that every disease has a developmental component to it. How does it start? How does it develop? What makes it worse? What makes it better? It builds upon rapidly expanding evidence in a whole variety of areas. And it's not just about connecting the dots between what happens early and what happens late. My grandmother could tell you that what happens early determines what happens late. Every novel that's ever been written is about what happens early, what happens late. It's really about what the mechanisms are and where the leverage points are, and so that we can really figure out what we can do and act in a different way. And this goes back to David Barker, and there's something called the Barker hypothesis. But going back into the 1980s, there was this guy, David Barker, who ran the epidemiology unit in Southampton. And they were looking at this notion of fetal growth and what was going on. And he discovered something that challenged the biomedical model in a really specific way. He was looking at, and this is looking at infant mortality across England, and this is in the 1900s to 1910s, and he saw a particular pattern. But he saw that that pattern was related to this pattern. This is heart disease in the same country in the 1960s and 70s. And he said, why is this pattern and this pattern the same? Why are we seeing this? Because it's 70 years of spanning. There's something connecting this. Something is going on in the same way, and it's being programmed into what was happening. And he put these dots together, and you draw a regression line through it. You see almost this perfect sort of relationship that happens. And what he showed was that birth weight and heart disease were related to each other in this group. And there wasn't really a way of explaining why is birth weight and heart disease related. Because what we thought heart disease was only about cumulative things. It was only about your exercise, how much you smoked, how much you drank, what you ate, and it was just building up cumulatively. He was raising something very different. Is there something about a sensitive period early on that something's being programmed into our bodies in a different way? And so he challenged the conventional wisdom that it was just diet and exercise. He suggested something different was going on. He argued that the nutrition, or in some cases malnutrition, was having an effect on evolutionarily determined biological mechanisms, and that the fetus was being signaled in some way that they were coming into an environment that was not going to sort of feed them or nourish them in some way. So it was upregulating a whole variety of systems. And when the nurses study here in the United States looked at the same thing, you saw that birth weight less than 5 pounds or 5 pounds, you had higher rates of heart disease, stroke, hypertension, and type 2 diabetes. And so it was playing out not just for heart disease, but a whole variety of things. And what started to become clear is that maternal malnutrition was about fetal malnutrition, and that what you saw were upgrading and the changes in all these systems. So you saw that you had, also led to hyperlipidemia, it led to decreased beta cell mass in the pancreas that led to changes in insulin, and there was greater insulin resistance, and you saw that the number of nephrons in the kidneys changes. So that all these things were happening, and happening early in life before the baby was even born. So this was part of, and I could show you, 80 or 100, 800 studies at this point that show what happens early in life lead to things later in life. And so that whether it's prenatal or in early childhood, you start to see it play out by the second decade. You see these things by the third decade, by the fourth decade, fifth decade, and on. So all of the major problems that we have and that we're looking at, the big things that we're trying to prevent across the life course all start early. In fact, we could say that Alzheimer's disease is a disease of early childhood. And because what we're seeing is that the brain and brain capacity and brain reserves are actually being set early on in life. And so this is kind of a radical notion. And what we're starting to understand, the model is that kids grow up in very complex ecological environments in which they're interacting with friends and family and neighborhoods and communities and systems and the physical environment and policies. And all these things are interacting with their body and their brain and all of this all at the same time. But it plays out in two different ways. Some are cumulative impacts, meaning that they're time dependent, but some are time specific, meaning they're being programmed during a sensitive period in the child's life. And because it's a sensitive period, there's something really happening there that's different. So that if a mom is depressed during the time from 9 to 18 months of age, you're going to have a child that will become attached insecurely. Or if something goes on in the family later, you'll see a change in language because these things are all coming online at different times. And what happens is this dynamic relational environment is basically creating all these adaptive changes in the behaviors in terms of all these neurodevelopmental issues. You're seeing all these physiologic adaptations and HPA axis and metabolic and immune function, and also in just overall development. And this leads to these different trajectories and pathways that get developed. This is the model that they use in these last two National Academy of Medicine reports, is looking at what are these things that influence these different trajectories. So you have these different pathways that are happening. And so this is a different way of thinking about health. And there's a set of, in a sense, a set of principles that develop out of this life course health development model. This is the main thing that I'm talking about. It's about how health develops across the life course, complex systems interacting, cumulative and time-specific interactions that set up different pathways. But there's principles that come out of this. And the principles are really important in the handbook that we've laid out and a few other articles. That health development integrates the concept of health and development into a unified whole. So we don't think about health and development separate, but there's this thing called health development that's common. And it unfolds over the life course, so it's constantly unfolding. That it's about complexity. It's health development's a result of these adaptive, multi-level, reciprocal interactions between individuals and their physical, natural, social, cultural environments. So issues of cultural focus and cultural rejuvenation is about how you create this complex environment and adapt and nudge it in the right direction. Timing is really important because health development is sensitive to timing and structuring of these environmental exposures and experiences. That plasticity that is built in by evolution is also important, as we saw from what David Barker showed, that you have these ways in which the body responds when it sees something that might be threatening long-term development. And it changes how we respond. That thriving is an important part because optimal health development promotes not just survival or striving, but thriving. And that becomes one of the things that health development focuses on. And that harmony is important. And harmony is important because there's balanced interactions between molecular, physiological, behavioral, and evolutionary processes. Each of these has its own time scale. Each cell in your body has a little clock on it. The little mitochondria aren't going 24/7. They're in phased rhythms because we live on a planet that goes around another planet, and all our bodies are tied to these rhythms. And each cell is tied to that, and each organ system's tied to that, and our communities are tied to that. And we have these evolutionary changes. So all this timing matters. And if it's not harmonious, what you end up with is a dysregulated and dysfunctional system. And this should potentially ring true to how many people think about the world they live in and what the nature of certain kinds of spiritual practices. It's about harmony and how we're connected to things. So this sort of principles, I think, can be very useful in how we think about and move forward and leverage some of what we're doing. So the simple way of thinking about this is we go into a trajectory during our life, and we can go into a high trajectory or a low trajectory. I'm really oversimplifying things. And you have risk factors that push down on your trajectory and protective factors that push up. You go into a low trajectory and you become symptomatic. So imagine that's my lung capacity, and I'm now, because I've smoked or some other thing that's happened, at age 60 I have COPD, or because of my metabolic function, at age 60 I have diabetes, versus having it at age 80. And this difference has cost the nation a huge amount of money. So part of why the United States spends much more money on things than every other nation is we're a sicker nation. We're the sickest of rich nations. And why are we the sickest of rich nations? We spend all our money once people are sick rather than investing in the success. So we pay for failure. We don't invest in the success of our population. And investing in the success is investing in their health. This is just showing for early childhood, the first 5 years. So just to echo what Ann is saying, you can go into a delayed or disordered trajectory, and we now have 40 to 50% of kids. And it has to do with these risk factors: poverty, toxic stress, lack of health care, all kind, you can name probably 15, 20 other things. And the kids that go into higher trajectories have all these protective factors. And you look at places where you have lots of protective factors, you have high biology of this. It takes more than having the right genes. It takes the right supportive experiences. Experience literally writes on our genes and determines how our genes work. We have this sort of way in which our neurons and our brains are being developed. And what happens is those neurons have various kinds of genes that tell them how they're going to function and work. But what we've learned is that experiences basically will write on those genes and change them. This is what's called epigenetics. And this has been a revolution in the last 20 years, of which how things in our environment actually get translated into our biology. So these epigenetic signatures change what's going on. And what we've learned is relationships are one of the most powerful experiences early in life that changes the way our genes come on and move forward. And that stimulation is needed for the brain to develop, because an infant can't stimulate themselves. They can't just lie there and get what they need. So it's really this relational nexus that's really, really important. Some call it serve and return. But it's the relationships that buffer the world for us, but it's also the relationships that help us grow and develop. And we know that adversity is bad for our brains. And what happens, and there's all kinds of adversity that happens because of social isolation and poverty and other bad things. We know that kids that have a lot of adversity are born early, smaller, more fragile, and are at risk, have worse physical cognitive development, are hospitalized more obese, more asthma, more mental health problems, lower health trajectories, greater sort of brain drain, carry the burden of their social status with them into adulthood. These things don't go away, and they're programmed into their biology and how their immune and endocrine system. That's what Ann was talking about. And this is all very clear now. So it really needs a different way of approaching. The biomedical approach, the 1.0 system isn't in tune with this. We've got this, we're completely out of sync on this. So how does this adversity look? This is from a very famous Hart and Ridgely study looking at vocabulary development. So you look at vocabulary development in kids where parents are college educated versus those who are poor. And you see by age 36 months, one group of kids has 1,200 words, the other group of kids has 600. So this is, in a sense, almost looking at what their SAT scores are going to be, but it starts early. You see by 16 months, you see the differences or disparities or inequities are beginning, and that they just continue to move forward. And this is the so-called 30 million word gap, because these kids are having a completely different experience. Their ecosystem is different. The pattern of their lives are different. So how do we change the pattern? And we know that this actually affects their brains, because when they've done brain scans and look at the same thing about social status and brain scans, you see the same thing. So that this is not just behaviors or neural functioning as witnessed by vocabulary development, but actually the brain is affected. And we could say, oh, that doesn't matter much, but what we have is about half of our children now growing up in low-income families. So we have half of our children that we're sort of saying, okay, we're going to have you have lower brain development just because you're a low-income kid. That doesn't seem fair, right? It doesn't seem fair. It doesn't seem to be giving everyone the chance for equal opportunity in this country, which is what we were sort of founded on. And what we know is that if we want to get kids to the right trajectories, there are different services. And again, this isn't rocket science at this point, and so that some kids need home visiting, some need special services, and we know how to customize these. So it's not a one-size-fits-all, but if we can measure trajectories now, we can actually target in ways that are doing very similar to the way you're measuring hemoglobin A1Cs and targeting what you're doing. We can measure all kinds of other stuff and target our response and make sure that we're optimizing these trajectories. And I'm just showing this because I'm really enthralled by this. This is in the state of Massachusetts. They have a whole movement across the state which is about building better brains. And they have this stuff all over, plastered all over the state. We do something similar in California. But this isn't about just services. This is about changing the ecosystem, changing how we think and feel and how we understand things. So reading to build better brains, counting to build better brains. So they've just how are we going to turn this around? How are we going to make sure that all kids are moving in those higher trajectories and moving forward? Now we can do the same kind of life course approach to obesity. What we know in obesity that there's a genetic susceptibility, but there's this risk change that happens, and the risks are not the same. So that we know that there are different risks at different points in the life course. So how do we target those? How do we structure what we're doing? Because we know these are sensitive periods in the development of obesity. And if we want to take a life course approach, we have to start thinking from a life course framework and using those principles, multiple levels, timing, harmonizing, and thinking about. Those become design principles in designing a new system, so that they help us think about what should the new system look like and move forward. And we have to think about the entire ecosystem at each point in time if we're thinking about obesity. And this is just showing the risk and protective factors different in terms of thinking about obesity. And I'd read these off if the screen wasn't so small over there, but I think you can see some of these. And also, I'll just say all my slides will be available to all of you so you can have them. I know I'm running through this, but this is just showing risk and protective factors at different points in time that have to do with nutrition and relationships and the whole set of things that Ann was talking about. And we know that adverse childhood experiences also have a direct relationship to obesity and weight gain and diabetes. So those are things that we need to address. We also know that the marketing that's going on, the $10 billion that's annually marketing to sell kids stuff that they shouldn't be eating. We know that the sugar-sweetened beverages that kids get. So it's not just calories in and calories out, though. It's a whole ecosystem of changes that need to take place. And we know that our markets and everything else is just designed for disease. And, so changing the pattern means changing all of this and taking a focus on this and sort of saying, you know what, we can do this. We can change how we think about it. The other thing is to be able to think across generations. So here are those same ecosystems and thinking about them in terms of the grandparents and the parents and the children, where they're growing up and what is influencing what, and how do we start thinking across. So this life course approach allows us to take this dynamic ecosystem and start thinking about it across generations and what gets transmitted in that process. So it helps us analyze, and we now have the science to show that this is how we do things. So we have to design differently. We're not designing for a single molecule anymore. It's not just measuring the hemoglobin A1C and taking care of that. We have to think about everything that's determining that hemoglobin A1C and where the leverage points are that we can actually make changes. And so there are now life course approaches to diabetes prevention. And this was just published recently in the PLOS, that it's looking at all the things that we can be doing across the life course that start to think about it. But the question is, yes, now we know what the mechanisms are. We know it starts early. We know it's about the ecosystem. But how do we change this? Because we don't have a healthcare system. We don't have a health system focused on a healthy ecosystem. What we have is a medical care system that's still mostly about acute care and chronic disease care. So let me just shift gears real quickly in my last 10 minutes and sort of say, so what do we do about this? So how do we take all this life course knowledge and this connection between what happens early and late and what's being programmed into us and how much of it is ecosystem, and let's relate it to our health policy challenge as a nation so that we're connecting the dots to this broader set of issues. So I'm going from cells to society and policy at this point, right? So we have the most inefficient, low value, low return on investment healthcare system in the world. We're going to spend $4 trillion on healthcare in the United States. We cut off more legs than most other countries because of how we spend our money. We have many other challenges in our healthcare system besides being low effectiveness, efficiency, and lack of return. We have incredible inequalities in our system. We have rising rates of chronic diseases. We have unavoidable demographic shifts that are going on as this whole group of baby boomers are getting older like me, and doing this. And we have these relentless cost increases. And we have a tired old anemic health policy that's still doing just more of the same, more of the same, more of the same. We're in the first horizon. It's all incremental stuff that we're doing. And so we have this big mismatch because we have all these 3.0 ideas and apps that we want to develop about promoting health and changing the way that we do things, but we're running it with 2.0 goals and 1.0 payment methodology. It's almost like we have old IBM Selectric typewriters or the first generation computer. We're trying to run the current software, and we're trying to run apps that I run on my iPhone, and it just doesn't work. We have things that are just out of sync with each other. So we proposed something a few years ago in health affairs that we call the 3.0 transformation framework. And the basic storyline is that we've had 3 areas of healthcare and 3 major transitions, and we're in the midst of a 3rd transition right now. First era focused on saving lives through acute care, emergency and rescue care, and public health safety. The second era was focused on prolonging life and decreasing chronic disease. And the third era will, moving forward, focus on optimizing health and well-being. And it looks a little bit like this. So the first era, going back to the 1850s, in 1900, when people only lived to be about 45 years, was focused on acute care and infectious diseases. This is where we came up with, used the biomedical model and germ theory, and it was remarkably effective in helping us do really important things in improving the health of the population. But it was really about short time frames. People got sick and we immediately responded. We weren't managing things over long time horizons. And we created our insurance model there, which was paying after the fact with indemnity insurance. And we built a healthcare system based on an industrial model because that was our major model of production. So hospitals look like big factories, doctor offices are little shops. They're all connected together in a production system that looks no different than most of the, like GM or anything else. It's just a micro version of it. And the focus was on making sure people don't die. As people started to live by the 1950s into their 60s, life expectancy is 65, we have a lot more chronic illness. We create all the National Institutes of Health, which are all just national institutes of different chronic diseases. And we come up with a different way of looking at things using this biopsychosocial approach. We realize all these chronic diseases aren't because of bad genes, bad germs, and bad luck, but are because of our behaviors and our social environments. And we start changing the time frame. So we're not managing things over days and weeks anymore, but we're doing months, years, and decades. And it's all about chronic disease management and prevention. We changed the entire way that we finance healthcare from indemnity insurance to prepaid health benefits because we know we have to screen for prostate and mammograms and all the other stuff that we pay for in advance because we know people are going to need it. And we're moving towards a corporate model of healthcare. You've heard of ACOs or accountable care organizations that are being created all over the nation, moving from volume to value-based payment. It's all about corporatizing. It's about basically the Kaiserification of the entire American healthcare system that's going on. And that's what the ACA was all about. It was about the corporatization of the healthcare system to have better control over costs. And the goal of the second era has been about prolonging life, not just prolonging life, but it's about prolonging disability-free life. It's about disability and helping people live. So now we're at a point that people could live to be 85 or 90 and perfectly healthy, And we know what it takes to do that. And we know that these life course issues are all what it's about. If you make the investments early, you get these longer trajectories. So we have a whole different scientific model, rationale, and design. So we're going to move towards more lifespan, life course oriented systems that are going to be about investing in the population health development over time. So as we start to develop our ideas for how we change health systems, it's no sense creating more 1.0 models. How do we start thinking about the 3.0 models, and how do we design for that? So what we've done is we've gone from a 1.0 medical care system, 2.0 healthcare system, and we're headed towards a 3.0 health system. The United States is about 1.8, and most of Europe it is about 2.2. The whole world is doing this because the science is driving it, the epidemiology, everything's moving in this direction. So how do we start thinking about what we want to do or what we're doing when we suggest something? Are we suggesting something that's 2.0? Are we suggesting something that's 3.0? You can hold this up. We're going to change something in one of the tribes. Is it just a 1.8 going to 1.9, or are we really trying to push the boundary? How are we trying to move this? And so it has a different operating logic, so we're not about absence of disease, but we're about health development. It's not about maintaining or health or prolonging life. It's about actively optimizing the health development of the population. These are different designs. You do things differently. You invest early. You act in a different way to achieve health. So there's a whole set of processes and different logic that we use. And there's a whole way that you organize your healthcare services. This is from Blue Shield of California. They're trying to move in this direction. So you move from regular old medical care to accountable care organizations to something that might be called accountable health communities or accountable health development system, in which we're really trying to actively develop the health of the population. So let me tell you how we're trying to activate all this knowledge and what we're trying to do to move towards a 3.0 system. So we have this 1.0 you see there, which is biomedical and just, the regular old doctor's office and hospital working on things. The 2.0, where you're trying to link things up a bit, and you got wraparound services for chronic diseases and coming up with better systems for doing things. But we have this kind of 3.0 idea. So all children thrive is how do we put in place a operating logic, a learning system, a way of innovating together that starts to change what we do and creating a national and international learning network so we get places that want to innovate together to start connecting up and sharing what they're doing and moving as fast as they can to do that. What we're trying to achieve is to optimize the health and development and well-being of children. We're trying to improve the conditions in which children live in. We're trying to change the systems that affect those children, so it's about the ecosystem, and it's about creating a culture of health development and resilience and sustainability. So I think the cultural kinds of rejuvenation ideas that are permeating through your communities and the kinds of changes fit with this kind of approach, multi-level, dealing with the problems, but dealing with the systems and conditions. And what we've been working on is a whole set of strategies about how do we think about financing different. If we were going to move forward, what would we do if we took all of the healthcare services that we now pay for one by one? Well, it's going to be different in the Indian Health Service, but out in the rest of the world, if we're not paying for each service, and we were to bundle all the primary health services together from 0 to 5, or minus 9 months to 5, and you were also to put all preschool, family support all into one bundle and provide it so that places could create comprehensive integrated programs so you didn't have all these different silos. So we're actually having a design meeting in a couple months about what ecosystem life course bundle would look like. And we're talking with the state of North Carolina and Washington, D.C. and California. Can we start trying very different? These are disruptive financing mechanisms. They're purposely disruptive, but we can get this to work. It'll start changing everything in which the way we organize. So we've been looking at all these different kinds of strategies. We're focusing on what we call big dot outcome measures. They're not lots of zillion different indicators that you need to have a public health degree or an RN or MD next to your name. It's things that my mom can understand, or the guy at the checkout counter at the Safeway will understand. Means that we're improving the health development of kids and that everybody can work on that in these communities. But what we're doing is we're focusing on cities, because what we're trying to do in California, and this is what we're hoping to do, we've got $10 million from our state legislature through our public health department. They want to deal with ACEs and trauma. We said the way to deal with that is change the ecosystem. So we're going to cities in California and say, we have this crisis of child well-being and youth well-being. We have these syndemics of mental health, obesity, neurodevelopmental disorders, and addiction disorders all going through the roof in our state and around the country. Do you want to be part of the solution, or are you going to be part of the problem? If you want to be part of the solution, city, Pomona, Pasadena, Anaheim, this is some things that you can do. And so at a level 1, we give them 20 policies to think about. Pick 2, and you get a designation as an All Children Thrive city. We'll teach you the handshake. We'll give you a hat. You'll learn the high sign. You'll become part of our community and part of the learning system that we're creating to be All Children Thrive city. Then, once we got you in and you're part of the club, you get a star if you have data on all your children. That's the second level. We have a bunch of capacity building things. So we're moving from level 1, which is about changing mindsets and changing expectations and changing identity. You're now an All Children Thrive city. That's how you build a movement, to building capacities. You get a star if you have data on all your children. You get a star if you have a mayor's office of child well-being. You get a star if you have a 10-year blueprint for child well-being. You get a star if you have a children's budget for your city, and we're creating other stars. We're working with UNICEF about get a star if you adopt child rights, the Convention on Children's Rights. We have things that we know are about improving capacity. And then that takes you to the third level, and the third level is transformation. And there are third level, third horizon cities that are starting to develop across the country, and there are places, not just in California that want to do it, but in Pittsburgh and Cincinnati and Columbus, and Washington, Washington, D.C. and New Orleans, and there are all kinds of places, San Antonio, I'm going later this month, that are all moving in this direction, because every place in the country realizes their children aren't doing well. Every place has a cradle to career, thrive by 5, success by 6, because they know at least half of their kids are struggling just to get to school ready to learn. And they know there's no money for it. All the money's tied up, and they're using United Way money, little bits of here and there, and we're putting little bitty programs out. And there are a bunch of places say, enough is enough with the incremental approaches. We need to do something more transformative. We need to move to the third horizon. We have the science. The Life Course Health Development Framework shows us that this is what we should be doing. So let's use the science, use our ingenuity, commit with purpose to really make sure that the next generation of children are going to be better off and not worse off. So that's what we're doing. I hope that this Life Course framework is useful to you, and I would encourage you to look at what we're doing around All Children Thrive and some of the other efforts to think about how the various Indian tribes and nations can sort of work with us and think about some of the same models. So thanks very much.
That was wonderful. What a great and fast tour through a lot of science, but that's exactly what we're ready to do, isn't it? And SDPI grantees, if you want to work on some of these things, haven't you been convinced by now that this is diabetes prevention or diabetes treatment? You want to work on stuff in the early life, you have some application times coming up now for 5th year of the current cycle, and hopefully we'll have a new funding cycle coming up, and you want to do some of this kind of work, put it in that application. We're ready. So we are very grateful, Dr. Halfon, for that excellent tour through this science and what's going on. We're part of something really large, and we can put our own spin on it, our own,